Welcome, welcome everyone. We have very talented list of speakers, panelists and advisors for this virtual side event during the 79th World Health Assembly, which started in Geneva, Switzerland on Monday, May 18th. Names, email addresses, and short bios of the speakers are available on the website. Link to access all this information is also available on the chat box. If you have any questions for the speakers, please feel free to contact them directly, but wait for the session to be over or write your questions in the chat box. To strengthen global trust in maternal and child health and to achieve United Nations 2030 agenda, scientific community needs to communicate their work and scientific process more effectively and learn from each other. The title of today's side event is Maternal and Child Health, Building the Capacity to Care. So let's get started. And all right, something is acting up here. Good, that's okay. Uh, Maybe I can close this. All right. Of all the health statistics monitored by the World Health Organization, WHO, maternal mortality and morbidity, both physical and mental, shows the largest discrepancy between the developed and developing countries. Uh, and every day, at least 700 women and girls die, one every 2 minutes. And there are a lot of people entering. Let me enter them and I will be with you. Okay. Um, and hundreds more have short and long term disabilities because of pregnancy and childbirth. 90% of these deaths and disabilities occur in developing countries. Anyone who has cared for a woman during pregnancy and childbirth knows that if physically ill herself, the mother and of course father, baby's father too, will be anxious, stressed, depressed, and sometimes inconsolable. What should we do? What can be done? In the real world, throwing money at global challenges does not solve any problem. Well positioned, well planned frameworks and programs are the way forward. Here is our agenda. Today's agenda is reviewing maternal mortality and morbidity trends. Data is from WHO, UNICEF, and World Bank. And fostering partnerships with communities, reducing digital divide, reduce fostering societies where everyone is included, open science, big data management, and open AI. This is the road we traveled, is our brief history. It is indeed our pleasure and privilege to share with you our brief history of this initiative. Women's Health and Education Center, WHEC, was established in 2001 to undertake projects and programs with the UN, WHO, and UNESCO. On 24th October 2002, worldwide platform womenshealthsection.com was launched in collaboration with the UN's Department of Public Information, UNDPI. Today, it is serving in 227 countries and territories. We serve about 14 million visitors every year. In 2006, to improve the curricula in maternal and child health, WHEC practice bulletins were launched to provide comprehensive information about various topics essential for clinical practice. Knowledge that touches patients is a work of various talented faculty from various academic institutions. I thank them all. Currently, we are working on expanding UNESCO chair program so that concept of internet classrooms in maternal and child health will continue to grow. Join our efforts. All are welcome. Health and education are the best building blocks, and our commitment to the lifelong educational efforts can be accessed via this link. Here it is the link of continuing medical education. Please review it at your convenience. Here are few of the examples of our collective advocacy and national and international platform. Towards education and health for all, core enabler of the UN 2030 agenda, was published by Division for Inclusive Social Development and UN Social Development Network. Here is the link towards education and health for all. Please review it. And we are thankful to WHO and Bulletin of the WHO for acknowledging our initiatives. These are their printouts, and I will always be grateful to UN Chronicle for publishing this article, Improving Maternal and Child Health Through Education. Here is available on web. None of us live in healthcare system. We all live in our communities and societies. Fostering societies where everyone is included is the way forward. Let us not leave anyone behind. Building the capacity to care. Imagine students in the developing countries and in the United States and in Europe simultaneously reviewing the same medical curriculum and learning from each other. This is e-learning, and it is at its best in the internet classrooms, and it is the goal of this maternal and child health essential knowledge portal, womenshealthsection.com. Preparing the next generation of healthcare providers in the international arena, deepening their knowledge, and improving the skill set for a career in global health and global governance is urgently needed. Empowering girls and women, minorities, and through education is the way forward. We aim to understand women's reproductive rights and how to balance these rights with the imperative that communities and societies will then be more likely to make good reproductive choices. Summary and takeaway messages are quality education and universal health coverage is a right and should be accessible to all human beings in every country, rich and poor alike. Women have a right to safe motherhood. womenshealthsection.com Internet Classroom is a vision for the globalized world. Knowledge that touches patients in this portal and pages is the contributions for many talented peoples and institutions. Women's Health and Education Center respects the reproductive laws of each and every countries and territories. We all at WHO also respects the rights of patients, colleagues, and communities. Thank you. And here, good. At least we are back to the screen. Now it is indeed my pleasure to hand over the platform to our friends and colleagues from World Health Organization, Department of Sexual, Reproductive, Maternal, Child Health, Aging. Wow, it's a very long department, my lady.
Yes.
Joining us from the department is Dr. Ulrika Reinstrom, and she is talking on expanding quality care through midwifery models of care, which I have tremendous respect for. Go ahead.
Thank you so much, Rita, and distinguished panelists and all that are listening here today. Let's see, Rita, if you stop sharing, maybe I can share my slides.
You should be able to. I think you tested it. No, working.
No, they are your slides there. So if you stop sharing.
I did click stop share. It should share. Share the host setting for share. Remove. Okay, I stop sharing.
Yes.
All right, if you say so. Otherwise, usually, okay, if I stop sharing. Now,
Yes,
you try.
please.
Go ahead. No, it won't work.
No, it's still your slides there.
Okay, still my slides. All right, all right.
There is the red bottom there up in the middle usually.
Okay, I stopped. Let's see.
Yes, excellent. Good.
Oh, wow. I'm glad somebody knows computers. Screen sharing
brilliant.
also.
Good, good. So now I will share my slides.
Oh, thank you for fixing the stupid computer. Good.
But can you see my slides?
Yes, I can.
I will put them on this one. Maybe you can see better now.
Yes.
Is it okay?
This is okay.
Okay, good. So thank you so much again for inviting me here today to speak on my topic, that it's really about improving quality of care for women and newborns. And let's get started. So we all know that quality of care gaps in maternity care still persist globally. And globally, major challenges exist still in inequities. We can see that in some countries, we have underuse of quality of care, essential or emergency care. And in some countries, there is overuse of interventions. Some countries have up to 80% of C-section rates. And we also see that fragmented and poorly coordinated care pathways, it's still a challenge. So WHO has launched a position paper in 2024 to speak to this one and to be one of many options, of course. But this is one option, and it's about midwifery models of care. And latest evidence has shown that there is a strong case for midwifery models of care. We know now that specifically continuous midwife care save lives and improve health outcomes, but also improve the well-being, the satisfaction of being pregnant and childbirth. We also see that the midwifery models of care is a care where there is a strong relationship and partnership with the woman, family, and the midwife, and also that it creates a trust between the two. And this trust is something that we have seen that is so important to have women to return to us as a healthcare provider, but also for the provider to have more confidence in providing care, because you know your client or your woman in front of you. You don't have to read the whole medical file. You know the woman very well because you have continued care to her. We have also seen that midwifery models of care, they are cost effective. And reasons are that because midwifery models of care reduces interventions and other things creates that we have long-term economical benefits. So it all really started from the Cochrane systematic review. And this is the second one that was published in 2024 by Jane Sandel and her colleagues, where they did a systematic review of randomized controlled trials, comparing continuity of midwife care to other models of care. And with other models of care, here can be shared care where there are obstetrician and midwives, or it can be obstetrician and nurses and midwives. So that other model of care can look differently. But the continuity of midwife care is when one midwife or a team of midwives are known to the woman and they provide care during pregnancy, childbirth, and postpartum care. And what was the results that they could see from this Cochrane systematic review? They saw that continuity of midwife care led to a high level of overall satisfaction of care by women and their families. So they were a positive experience for women. And then something also very important, that it's improved maternal health outcomes. So they could see that there were a high proportion of women that had vaginal births and less C-section and less instrumental births and other intervention. They could also see that this was cost-saving model, especially for antenatal care and postnatal care. Then in 2026, in February, this study by Coupiers et al. Was also published. This is not a randomized controlled trial. This one is a study that looking at case control and cohort studies, and they use the meta-analysis to get to the results. And what they could see, we know that randomized controlled trial are the golden standard, so to say, and that was the Cochrane. And this one is building on that one to try to provide even more evidence. And what they could see here, they included, this was also systematic review, and they included 17 studies. And similarly, they could see that there were spontaneous vaginal birth was more likely. You can see the odds ratio there, 1.16. And there were lower rates of cesarean births, and similarly for neonatal admission to NICU and preterm births, and again, a higher satisfaction and cost effectiveness. What this study, though, didn't show that there were a reduction in PPH, postpartum hemorrhage. So you could see that the odds ratio crossed 1 there, so it wasn't statistical, but it's very close. And I think it's super interesting anyhow, because it shows that there is a trend, and at least it wasn't more PPH. And this was also before, these studies were before the PPH bundle from WHO was rolled out. So there is a trend, and it's super interesting data also from this research. So based then on especially the Cochrane evidence, WHO together with our strategic technical advisory group developed the global position paper, and this is the dark blue document to your left. And you also have the QR code there if you would like to scan. And you have this document now in English, Spanish, Arabic, and French. And this document really speaks to why it's so important and what midwifery models of care is and what is not. Then in 2025, we launched the implementation guidance. That is the document there in the middle, and you have a QR code here as well. And similarly, you can find this document through this QR code in English, French, Spanish, and Arabic. And this document, again, it's more like a handbook, a technical handbook, or a true guidance document, very practical one, on how to transition, what you need to think of, where do you start, and it also presents a transition framework with 8 transition areas that are important to transition to midwifery models of care. The third document you see here on the screen to your right, it's the Midwifery Accelerator. And this is a coalition of partners, WHO, UNFPA, UNICEF, JPIGO, and the International Confederation of Midwives. We have come together and we agree to collaborate and to join forces and to support countries who wish to transition to midwifery models of care. So here you can see now on the screen the WHO definition of midwifery models of care, and this one is presented in the position paper. So it's really a way to optimize your health workforce and health system to meet women's needs and newborns' needs, and also families' needs before, during, and after pregnancy. So the continuum is very important. And it's very much focused on quality care that is coordinated by the midwives. Not only midwives, but midwives collaborate very closely interprofessionally with OBGYNs, maybe also nurses and pediatricians and other healthcare providers. And the midwives, they provide autonomous care, and they make their decision within their scope of practice for that specific country. And like I mentioned before, that the evidence has shown us the best result we achieve midwifery models of care is when we have the same midwife or a small team of midwives, 5-8 midwives, that are known to the women and care for the women through her pregnancy, childbirth, and postnatal period. So very quickly, these are one of the few of the guiding principles, that it's a person-centered and respectful care. The woman and the newborn is in the center. It's not the healthcare provider, it's not the midwife that is in the center. It's really focusing on the woman, the newborn, and the family, and their needs. And like I mentioned, it's the trust and the relationship-based care. So it's completely opposite to fragmented care, where women can meet so many providers during their pregnancy and childbirth. And then this last point there in green, that midwifery models of care, they are focusing on the natural process, and interventions are only needed when really necessary. So I think this is very important for all countries, because we see over medicalizations in many, many countries, and women are losing their belief in their own body to actually believe in their reproduction and their pregnancy pathway and childbirth. So where can then midwifery models of care be placed? So to start, I think it's really good for countries to think about how to have midwifery models of care at primary health care in the communities, because like you have seen, it's very focused on closeness to the community, to the families. So very much primary healthcare settings. But of course, midwifery models of care can also be in hospital-based settings, even in private sectors and humanitarian crises. So these are the 5 different models that we present in the implementation guidance. So we have the continuity of midwife care. Then we have something that we call birth centers. This name can be different in different countries, but it's really where there is a low-risk unit that midwives are coordinating, and it's usually next to say, a high-risk unit within the hospitals. So women where we anticipate that everything will be very normal and straightforward, and where women choose to have midwifery models of care, they would be channeled to say a birth center. And more high-risk women that are maybe already having high blood pressure or some other complications, they would then be in these other settings that is more high intensive care, say. And then there are different kind of models, and countries, they can adapt and they can develop their own model, as long as they stick to the guiding principles, of course, of midwifery models of care. So scaling up midwifery models of care, it requires a little bit of rethinking, because it's not anymore the provider in the middle or the primary healthcare center in the middle. It's really the woman and the newborn and the family that we put in the middle. So it would need some kind of restructuring within the health system, or a change. And of course, we need to have strong leadership and policies and strategies. So a political commitment and funding is really important, because it's not a short-term fix. This is a long-term investment. Then, of course, the regulation needs to be in place, both to protect the women and the newborn, but also the healthcare provider, of course. So we have also seen that partnership and community engagement is another pillar that is very important, that women, they understand what midwifery models of care is and what it's not, and creating that demand from the women as well. So these are the pillars, so to say, to then be able to have a sustainable midwifery models of care in place. So I have shown you some of the evidence here today, and some of the WHO global guidance documents on midwifery models of care. But evidence is not the change. The documents won't change anything. So it's really through collaborative implementation that we can reach our goals. So I thank again for the invitation to be here to speak with you today, and let's work together so we can make midwifery or continuity or midwife care a standard in many countries and not an exception. Thank you so much.
Thank you. And I agree with you. And I'm glad in United States of America now, midwifery care is with the clinicians. And I loved working when I was in clinical medicine. I loved working with all the midwives. They were angels. Anyway, now I have to give it my floor to my dear friend, Dr. Colleen Kraft. She's joining from Los Angeles Children's Hospital, University of Southern Texas. She was 2018 president of the American Academy of Pediatrics, and her presentation is on two-generation approaches to building healthy children and communities. Go ahead, Colleen.
Okay. I will mention it's the University of Southern California. One little difference in there. We're going to talk a little bit about two-generation solutions. So once we have the babies who are born, and we have mothers and children working together, parents and children working together, the whole idea behind two-generation solutions is raising healthy children by supporting the entire family. It is a framework and not a single program, but what it encompasses is, first of all, early childhood education, which is really high quality, accessible, developmentally appropriate learning for every child. And that really goes from infancy. If we have policies that are looking at parents being able to be home with their children in the early months, the next best thing is really going on to early childhood education. What's developmentally appropriate and safe for that child? While at the same time, we are looking at post-secondary education for parents. These are pathways to credentials and certificates and degrees for those caregivers and parents. Because what we know is that two-generation approach increases economic assets, but that's not something that comes naturally to a lot of people. So benefits access, how do you save money? How do you do financial coaching for lasting stability? All of this really is rooted in health and well-being. So with our families, how do we teach good preventive mental health and nutrition? How do we help to provide housing and stability for the whole family and teach people how to budget for these sorts of things? And then finally, the idea of social capital. Where are the peer networks, the community connections, and then mentorship for sustained growth? This is rooted in equity and parent expertise. And families are not just the recipients, but they are the co-designers of these programs. So if you think about two-generation programs, they are two services, but it's one family and one strategy. So quality early learning, so developmentally rich environments for children birth through 5 years of age, workforce and career training, job skills and coaching and pathways to sustainable employment, and included in that post-secondary education, so the credentials and certificates for caregivers. All of these things help to promote economic security, health and well-being, and then social capital. The odds are really stacked for both generations. For our families living in poverty, we have 10 million children living in poverty in the United States. And almost half of those kids live in homes where there is no adult who holds a college degree. And that we know that parental education is one of the strongest predictors of a child's outcomes in the family trajectory. And as the quote says, you cannot sustainably lift a child without lifting the family around them, which is all what two-generation programs look to do. So there are some really wonderful models out there that lift both generations. Career Advance is one of them. And some of the components of this are looking at, for parents, tuition-free healthcare training. So some of the areas where we need healthcare workers, nursing, medical assistant, health IT, career coaching for families, peer cohorts so they can learn from people who are really doing the same sorts of things and traveling the same path. And then financial incentives, stipends and supports for economic barriers. For those children at the same time, full day Head Start, so high quality early childhood education. Really looking at synchronizing schedules. This is such a problem for our low-income families in the United States that you may have a child who's got a great early childhood program, but the parent has to work 2 hours after the childhood program closes. That puts a barrier in place. And so children are not attending these programs because parents can't work long enough to get their children out of them. Or you have parents who put their children in these programs, but they can't work because there's no one to take care of that child for those 2 hours. Synchronizing schedules is something that really works for parents and children. That early literacy and enrichment, that it is so important to be able to get children to play with each other, learn how those social skills work, looking at books and literacy. So many of our families now, when their children are bored, they give them their phone, they put them on to a video. And this is not something that teaches these children early literacy or developmental interaction. It is having that in person and having those books there that will really help these out. So, Career Advance is one that provides both the education for the parents and the important early childhood education for the kids. When families rise together, children thrive. What we know from Career Advance is that these children attend more days of Head Start. It doesn't seem like a lot to have 6 more days. But what we know is that this actually translates into chronic absenteeism for kids when they get into school. And that as you get kids into school later on, the kids in this program have about half the amount of chronic absenteeism as a control group. That parents achieve significantly higher healthcare certification rates after just 1 year. Really important because when you talk to a parent about, well, you need 4 years of training for this, that just seems insurmountable. But 1 year is doable. There are 10 years sustained gains and longitudinal effects in both parents and adolescents, and that there is stronger mental health in both cohorts, and a return on investment of $4 to $7 for every $1 invested in these two-generation programs. Here are some other proven models across the country. Head Start and Early Head Start. This is federally funded early education and comprehensive family services for children birth through 5, including parents, addresses health, nutrition, social emotional development, and family well-being, right now serving more than 1 million children annually nationwide. Parent home visiting programs have a lot of evidence in terms of helping these parents thrive and helping these children thrive. And then parents two-generation pilots are happening all over the country as well too, where there is community college programs that include early childhood education so parents and children can promote their skills at the same time. Home visiting programs are really important. And what happens with home visitors is that they will meet the parents where they are in the home. It keeps some parents from having to travel somewhere with a child. But those home visitors can check the child's environment. They can teach where the child and family are comfortable. They can often teach parents how to play with kids and how to interact with kids. We find that many of our parents who live in poverty are not used to having a word-rich environment, a play-rich environment, a literacy-rich environment, and home visitors can help to fill that gap. They can identify social and material risk factors and really become a trusted part of the team between a clinician, a school system, and those parents and families. For pediatricians and my colleagues, we're finding the exam room is really a two-generation gateway because what we can do while we are seeing these children is screening them for social determinants of health, looking at warm handoff referrals within the office, having a social worker, having a referral system where we can have parents who have been through training work with our parents who are there. Ask about parents and not the children. One of the standards of care that is happening now is maternal depression screening. We used to not do this, but what we realized was that that mother's mental health was really important in the development, especially early on in infancy. So now we actually ask about it. And in the United States, insurance is actually paying us now to ask about maternal health and direct those moms who may be depressed to the proper resources. We partner with two-generation programs locally. I'm going to talk for a minute about Healthy Steps, and because that's one that we actually use in our practice here. And then together you can measure those family outcomes, tracking caregiver well-being and child health metrics in the practice. So Healthy Steps is a wonderful evidence-based program where we co-locate social workers in pediatric offices. And what we do is we have them available for our 0 to 3 parents and children if there are social determinants of health that need to be addressed. So when we find that there may be maternal depression symptoms, our Healthy Step folks can talk with those families about where that mom can find some help for herself. If we have housing insecurity, last year during the fires in Los Angeles, many of our families lost their homes. And our Healthy Steps folks were wonderful in terms of finding both temporary and then eventually permanent housing solutions for many of these displaced families. They provide appropriate developmental education as well, too. We find that many of our families who live in poverty really need some developmental education and understanding of their children. And our Healthy Steps folks can do that. Last week, I had one of my Healthy Steps workers explain to a parent why it is that the parent was really concerned that their baby didn't like them because they cried all the time. And our Healthy Steps folks can take a little bit more time to explain what's developmentally appropriate for a baby and how you can play and comfort and be resourceful in helping your baby because that helps that mother. Again, two-generation solutions. For educators, we have many of our educators now hosting family nights that build parents' own learning and goals along with their child. They connect families to adult literacy and GED programs. They offer flexible schedules and then on-site childcare for parent engagement events. Really important too, because a parent may want to go to an event, but if there's no childcare, then they're not going to make it. So having childcare is really important. For families looking at pursuing their own education and engaging in home visiting programs are really important. And what we find is that many of our parents who have been recipients of home visiting services often will go on to train as a home visitor, and so they can pass that skill on to the next family. We look at turning research into reform. So Head Start integration, how do we align eligibility, those schedules of work and school and the schedules of childcare and funding streams so that parents can attend school while their children are in care? This maximizes all of the services that we have for families. How do we align this with childcare subsidies so we expand access and quality through childcare and development funds? Because that enables parent participation in education. How do we look at SNAP, our supplemental nutrition services, and Medicaid as two-generation hubs? Because these benefits access touch points to families for education and workforce. How do we expand home visiting and align that with college community program enrollment so that parents are learning, parents are achieving certificates and skills while there is robust early childhood education with flexible schedules? Because this becomes that legacy that passes forward. We have all of the evidence for two-generation help that shows that there are sustained gains for parents and children across 10 years. This is very much like our last speaker who talked about we've got the evidence, we have the policies. What we need is the implementation. Siloed programs are not enough. So child-only programs or adult-only services miss that multiplier effect of whole family investment. Every sector has a role, the medical sector, the education sector, and then policymakers hold a lever for change. And equity is the engine, two-generation approaches where we are helping the family rise Explicitly, it addresses structural inequities that block family thriving at the root. So start where you are, screening, referring, partner with one organization, one program, and you can see what happens when you include both parents and children and helping the whole family rise and help that family have one strategy and limitless impact. Thank you.
Thank you, Colleen. That's excellent, as usual. From India, joining us is Dr. Manisha Jawahar, obstetrician and gynecologist consultant. Her presentation is on Beyond Survival, Rebuilding Lives After Near Maternal Misses. Go ahead, Manisha. Oh, thank you, Ulricha. I should thank you. You fixed the computer. Go ahead.
Can you see my slides?
Yes, we can see the slide. We can hear you. Go ahead.
So during World War II, to make the fighter planes more efficient in surviving the attacks, the planes that returned from the battle were inspected and they were all found covered with bullet holes along the wings and fuselage. Everyone believed the wings and fuselage take the maximum attack, so they should be doubly armored. But great mathematician Abraham Wald strongly disagreed, saying these are survivor planes. In spite of the bullet strikes on wings and fuselage, they managed to return. We have to look the planes which crashed in the war and reached at the bottom of the ocean. They do not have holes on the wings or fuselage. Rather, they have holes on the front and the rear part. So actually, we need to armor this part to save the planes from crashing. Moral of the story is it's important to know the right cause of failure to improve future outcomes. Today, I would like to draw your attention towards a subject which has been a cause of celebration for entire medical fraternity, but at times a cause of misery for the survivor. India has approximately 50,000 deliveries per day and approximately 2,100 life-threatening events per day out of these 50,000 deliveries. Thanks to all the upgraded ICUs, management, blood bank availability, we are able to save nearly 2,000 such women and only 75 lose the battle. Because childbirth is not less than a battle. Now, what is the outcome of these 2,000 women, the maternal near miss, which have survived the near death event? Near normal recovery in 60%, but nearly 30% shows some problems for a long time. They approximately 200 women per day. The 10% becomes the nearly two. They have a disabling sequelae and they have to remain alive with this for throughout their life. And 600 women have minor health problems. This may be probably an underestimate because many events go unreported. So while we celebrate their survival, many of these maternal near misses actually suffer and keep on thinking why they survived. Every woman in India has a right to live with dignity. Does this life, like an animal, dignified in any manner? Shouldn't our aim to give a dignified life to a woman apart from saving or beyond saving? So both WHO and Ministry of Health and Family Welfare in India, they have robust protocols to prevent death. But unfortunately, neither of them they have devised a structural pathway to help the survivors of near-death event lead a life with dignity post-trauma. WHO says it has emphasized that we should follow, but it has not been followed or no protocols are still there. And without doing a fourth delay, these three delays have landed the women in ICU. Now, the fourth delay from our side, the healthcare side, can also disrupt the life of these survivors. So it's high time we take steps to avoid the delays so that our ICUs are not flooded and we are not drained of our systems. So now the $1 million question is how? Because all the delays have led to so many maternal near miss, and just now Colleen was talking about 2 generations. To secure future, to secure health, we need 2 generations. What about the children of these women? Many of the children, many of the women have died, so they are childless, so they are motherless, or you can say mother is either weak or at times very sick to support the child. Because every maternal near miss means neonatal near miss for most of the thing. Because neonate bonds to such mothers are 14 times, they have higher chances of landing in neonatal or NICU or neonatal intensive care unit because of prematurity, because of maybe low hemoglobin and other maybe infections. So it is very important that we take care of these maternal near miss to save the neonates and to reach the goals 3.1, 3.2, 3.4 would not be possible if maternal near miss is not taken seriously. A very absurd thing is these maternal near misses, they occur in clusters. We can often see it is being repeated in families, it is being repeated in community. Why? Because communities share certain biological factors. There is a predisposition to hypertension or hemoglobinopathies, thalassemias, diabetes, other metabolic diseases. Then we have certain inheritance of social factors like chronic malnutrition, like anemia. This is seen in communities, early marriages, poverty, because the community behaves in the same way. Then, unfortunately, the health system inheritance. One lady has died few days back because she couldn't reach the tertiary care center. And the same delay, the same geographic barrier occurred because the other lady from the same community was not able to reach the healthcare facility. So, how about upgrading these maternal near miss survivors to savior role? Urlika was talking, if a midwife is same for 9 months, patients develop better connectivity. Just imagine if we have a person from the same community, what would be the level of communication, what would be the level of trust, and what would be the level of following. So these maternal near miss, those who survive and those who are in good health, they usually have long-term mental side effects because they feel unwanted, the society rejects them. So they will also feel wanted, they will also gain back their confidence, and they will also lead a dignified life. So this is a symbiotic relationship and much cheaper than spending on ICUs, than spending on blood bottles, spending on healthcare facility. These maternal near miss, we need to find out the cluster areas which have so many maternal near miss, identify the maternal near miss cluster area, identify the maternal near miss from that area, educate that maternal near miss, and this maternal near miss will exactly communicate in the language which the people want to hear. She will be able to communicate the problems which she had faced, and she knows where the community has resistance. So this is a very, in terms of return of investment we were talking about. So in terms of return of investment, I think this is a high return for very low investment. So we need to begin a pilot study. I Lika or Colleen can also try because this is ultimately going to affect child health also. So thank you all for patient hearing.
Thank you, Manisha. It's always a pleasure to listen to you. Okay, we are fortunate to have Dr. Edith Luhanga from Africa. She works for Carnegie Mellon University, which is in Pittsburgh, USA, and Rwanda, Africa. Edith is the assistant research professor in Africa. Her topic is users' perspective on AI for health. Go ahead.
Thank you very much, Rita. It's a pleasure to be with you today.
Yeah.
I hope you can all see my screen.
Yes.
All right. So, unlike the previous speakers, I come from a computer science background. My research is on human-computer interactions. So, I study how people use computing technologies and how we should design them better to help people achieve their goals. And I'm especially interested in health and financial behavior change applications, particularly for youth and maternal and child health. And being in this space, one of the topics that has really dominated our conversations for the past 3 years, and I'm sure it's dominating the conversations in other fields as well, has been the role that AI, and particularly generative AI like ChatGPT, is bringing. It's been the fastest adopted software product in history, currently having about 800 million weekly users, and it's reached users in 209 countries. And so it's really one of the most engaging technologies that we have. And of course, it's making its way into all sorts of health applications. We're seeing conversational AI being used for patient onboarding, question answering, mental health support, diagnosis, and even helping patients summarize and later get explanations for what their health workers were saying during health consultations. And especially here in Africa, where there is such a large doctor-to-patient ratio, some of these applications are really being trialed for supporting patient care outside the regular clinical hours. But beyond individual level interventions, we're also seeing AI making its way into groups. It's mediating group therapy sessions. It's providing cohort-based behavior change support. And when we come to the evaluations, we see that when people use it, AI is actually quite effective. We are seeing positive health outcomes, but we're also seeing that there are some safety challenges. We have hallucinations, so where the AI provides false information, but it might not be detected by the users, but also some biases, especially if you're from an underrepresented group, because AI tools are trained on human data, and the majority of it comes from the global north, which represents only a minority of the world population. So users from the global majority countries might be missed by some of these AI tools. But a conversation I don't feel we're talking about enough is what people say and how do people think and feel when they use AI. And I think this is something we need to talk about more beyond just the HCI space, because there's a lot of contradictions that if we don't pay attention to, we might actually end up missing the opportunity to use AI to really push health outcomes forward, kind of like just about 20 years ago, we missed the opportunity to use the smartphone revolution to really reach people. So let me give a little bit more context. If you remember just about 20 years ago, when smartphones first came out, it seemed like everybody wanted one. They were useful, they were cool, they were just a joy to have. And as they became cheaper, they really just permeated society. It felt like everybody was starting to use a smartphone. And because of that, they were also adopting the internet and social media and a lot of these other internet-enabled platforms at a much faster rate. This is true even today. Here in Africa, we now have 416 million people who are using the internet, most of them through internet-enabled devices like smartphones. So even though it represents a minority of the population, just 28%, 416 million people is actually more people than in the United States. So we have quite a large number of people on the internet, and we have initiatives like this Connect Rwanda initiative, which is aiming to have one smartphone per household across Rwanda, which essentially means that once this goal is reached, people will have easier access to a smartphone than they do to a doctor. And this is true maybe even in other countries as well. And what smartphone revolution really represents was the wealth of data it provided, just based on the sensors that are on these devices, but also the fact that once you own a smartphone, you're also maybe going to want to own a tablet and then a smartwatch as your income expands, but also you start using the internet more, from search engines to social media. We get a wealth of data of where people go, who they're interacting with, how active they are, what activities they do, offline and online. And we also get a feeling of what they think or feel. And this data is very useful, especially for behavior change, because there are models like this COM-B model developed by researchers at University College London in the UK, which helps us diagnose why behaviors happen and why they don't happen. So it comes down to three things. People need motivation, capability, as well as opportunity to be able to do a behavior. From the wealth of online data, we've seen tons and tons of studies looking at what causes barriers to behavior change in various ways. And once we have these insights, we're then able to use other frameworks like this behavior change wheel, which then maps the cause of behavior or non-behavior to the right intervention functions and policy interventions. So for example, somebody with a lack of psychological capability, so they don't have the knowledge or the skills, will need interventions around education or training or just being provided with enablement support. So with the fact that we have so much data, smartphones are ubiquitous. They're in so many communities and they're everywhere with us. There really was this belief that we could provide personalized, just-in-time support for everyone when it comes to behavior change, but the reality has been quite different. Studies published up until 2025 are showing that majority of mobile health users are actually uninstalling their apps. 70% are doing so within the first 3 months, 53% within a month. So what are we getting wrong with all this opportunity? When you talk to the users, they say things like, well, I just feel like there's just too many features that I don't have, or the features are paywalled that I do need. Or that I lost motivation, the app wasn't fun to use, so I abandoned my health goal, and all sorts of reasons why we're not able to meet their needs. And when you look at the research, we're seeing that we're not even including the right behavior change interventions in there. So there was a study back in 2021 that showed for maternal health apps, for example, only 7 out of 93 possible behavior change strategies were included, and most of them were just reminders. And so I come back again to this topic of we need to pay more attention to what people say, because despite these studies that are showing us we're not really reaching people's needs with smartphones, there hasn't really been an improvement in the quality of smartphone applications out there for health. We're seeing lots of evaluations of child nutrition applications that are showing just medium quality, not really high quality apps. So we need to pay more attention to what people are saying, even with AI, so that we don't miss what their needs are, and we can make sure that we're having more positive outcomes on health. And so let me get back to what are people saying about how they feel and how they use AI. So several studies have been published around how people view AI responses, so responses from tools that are large language models like the GPTs versus human doctor responses. And we are seeing that they trust and prefer these responses mostly because they're more empathetic in nature and they sound more confident. So confident that some studies are showing experts are actually unable to detect wrong information. So unfactual information if a source is not provided. But despite the fact that they prefer these responses, they still prefer interactions with human doctors. This is important because as we're doing more outsourcing to AI, more question answering to AI, and we're even talking about more patient-facing care being outsourced to AI, are we actually going to be doing what people need? People want the human connection, and that's not something AI can provide. It can provide an empathetic and confident response, but it doesn't provide the emotional connection that people need. And we might end up turning people away from healthcare seeking if we're not careful to get that balance right. Another contradiction we're seeing is, well, people still do use AI tools for health. So why are they using them? When are they using them? Especially when they prefer human doctors. Some studies are showing, this was a 2026 study with Copilot to look at when health questions come in most. They're seeing a trend that usually it's when physicians are unavailable. So evening hours, for example, people are more likely to use these general purpose AI tools. This is concerning because most of these tools were not created for medical cases, and therefore they're not compliant with regulations like HIPAA that protect privacy and confidentiality. But we're seeing people still share quite personal details, sometimes sensitive personal details, because they want more personalized responses that are more useful to them. Now, in this particular part about people sharing more data in order to get more personalized responses is interesting because as many of the previous, actually all three of the previous presenters have mentioned, healthcare is a team effort. I've been working on designing applications to support feeding difficulties in children with autism. And one of the things we quickly learn is how much interaction and collaboration there are between multiple types of health workers and the caregivers themselves. So the caregivers themselves are involved in the daily feeding of the child, but you do have the doctors, the nurses who are there to track developmental milestones, who help do the diagnosis. And you do have therapists who come in to help provide occupational therapy, behavioral therapy, sometimes speech therapy to address some of these feeding difficulties. Imagine a situation where all of these people are using AI and they're mostly using it because they're unable to get access to one of the other partners involved in managing the feeding difficulties at that moment. So they need advice or support right now. They're using AI. They're using different language or writing style to prompt the AI, but they're also providing different contextual information to get more personalized responses. The caregiver is probably providing more information about the child's behavior and at-home context. The health workers are providing more of the clinical side of their interventions and how the child is responding to that. What happens if the AI responds with a different answer to all of these parties? How does that influence trust dynamics? How does that influence communication and collaboration? And how does that influence health outcomes over the long term? These are questions we seriously need to consider if we are to create tools that actually work safely in a bounded way, not just in terms of lack of biases, but working in a way that people understand and that doesn't harm the interpersonal relationships we have offline. And so since 2024, I've been working with a speech and language pathologist at the University of Witwatersrand, Dr. Sky Adams, through seed funding from the Carter Foundation and Puthuka grants. We have established the Autism Research Lab Africa, where we have been looking at how caregivers and health workers are already interacting with AI, some of the challenges they face, but more importantly, we're asking how do they want to interact with AI for their individual support, and how do they want the support they get to influence the interactions they have with health workers, and do they also envision a role that AI should take in their interactions with these health workers and wider family members who are part of caring for the child as well. We have been running global interview studies to get more insights on this, but my hope and wish is that there will be more conversations about how people think about and use AI, and then using this data to design tools that are not just safe and effective in terms of accuracy, but also in terms of cultural values and relationship values. You can get more information on our work from the website by scanning the QR code, but also some of the other work I'm doing around maternal health and AI through the QR code on the right. But thank you very much for listening, and back to you, Rita.
Oh, thank you very much. It was excellent as usual. Now, coming back to hometown from Westfield State University, Massachusetts, presenting today is Dr. Lamis Jarren. She is an inaugural Executive Director of Research, Innovation and Design and Entrepreneurial Center RIDE. Its caption is RIDE. She will clarify, I'm sure she's right here. Her presentation today is on crafting change, how accessible design tools are transforming contraception education for women's health. Go ahead, my dear.
Okay, thank you so much, Rita, for this opportunity to engage in these critical conversations. I just want to make sure that everybody can see my screen okay?
Yes.
Okay, fantastic. All right, and I've got these pop-up. I'm so sorry, I had pop-up windows and they closed off my screen. So let's try this again. Okay. I don't know why it's asking me all of these. Okay. Not sure why it's happening. It keeps I'm gonna try to ignore it.
Oh,
Hold on a second.
I don't mess with the computer, but
I
I'm
know,
glad
I don't blame
he
you.
fixed it.
Okay,
It's
so
working
if you
well.
can see my screen, I'm
Yes,
gonna
we
go
can.
ahead and just start presenting. Hopefully you can't see what is I'm seeing. Okay, so this is a collaborative project that I will be sharing, and the conversation is really about different ways of communicating and educating users and students about women's critical aspects of women's health. So it's really about having accessible design tools that can transform, in this case, contraception education for women's health at Westfield State University. Um, my collaborators, two of them are not able to be here today. They are Dr. Jess Stevens and Dr. Robin White. They are both professors in the biology department. And then my colleague, Grace Templeton, is here today. She is a coordinator of the RIDE Center. I'll tell you a little bit more about the center. And my background is in molecular and cellular immunology, especially as it pertains to organ transplantation tolerance. And so, as you can imagine, pregnancy is a transplantation that is natural, but something that, is very interesting to me as well. So, this is the RIDE Center. This is the Research, Innovation, Design, and Entrepreneurial Center. And the center is focused on accessibility to all users, regardless of their major, their year, their interests. And it has a multitude of fabrication design tools and technologies. And I have a video here kind of showing you how these tools work. So we have everything from, Cricut machines for designs to mold making, 3D printers, laser cutters, electronics and connected devices. So really focused on computer programming, mold making, glass fusion kilns, really anything and any tool that you can imagine to help you prototype an idea and bring it to life. The center is about de-siloing who gets to have a seat at the design table and really kind of removing these ideas and perceptions that you have to be an engineer to come up with a really good idea, or that you have to be a business major to launch a successful business. I'm an entrepreneur, I'm a scientist, but I really want to come at this in a very diverse way. So I was honored to help establish this space, and you can see the different ways that it's utilized. Some of the ways that the space is used, or part of what I try to do internally, is work with faculty members. And here's an example of a faculty member, Professor Georgia Ramirez, and he teaches typography and digital art design. And so the professors that I'll be talking about today are teaching a really interesting pilot biology course called Exploring Complex Issues. And this is part of our reform general education approach. And my job is to try and help these faculty members utilize the center in order to either create models that better explain very complex theoretical ideas, or to bring their students to the space so that they can utilize the fabrication tools and technologies to demonstrate their understanding of the concepts. So in this pilot biology course, the professors are exploring complex issues that are focused on reproduction and pregnancy. Specifically, what are the processes and the risks that are involved in this complex journey? Pregnancy is, they want them to look at pregnancy through various lenses that include biological aspects, molecular, cellular, complications, and more importantly, societal disparities and reproductive outcomes and access to education. I'm sorry. Oh, you can't see my screen? Oh, sorry. Can you not see my screen?
I can just hear Cecile. Screen
Oh,
has started to share, but I'm
oh,
not
okay.
seeing the slides.
I'm so sorry. Grace, can you help me out?
Oh, I understand, Lamas. I fight with my computer every day. Don't worry.
So sorry. Hold on.
Showing it first.
It was showing it at first. Okay.
Have an icon on the top of the screen. Start sharing. Have you clicked that icon on the
Oh,
top of the
there is nothing sharing here.
start share?
Maybe I'll start share. Allow.
Okay. I'm gonna stop sharing and try this again.
What window do you want to go to?
It's the Canva.
Okay, so
Controlling. No. Sorry.
That's
Wasn't sure
okay.
what it does.
window.
Yeah.
I don't know.
Mm.
You want me to screen share for you?
Yeah. I'm gonna have Grace screen share if that's okay. Rita, can
That's
you?
fine. That's
Thank
fine.
you. And I will
Whatever
talk.
works. Yeah,
We're a
because
team
everything else
here.
has worked. Go ahead. Go ahead. Go ahead.
As the other speakers have indicated, we're all a team here, and so
Yeah.
it's a shared.
Yeah.
And you'll have to let me know if Grace is able to share it.
Yeah.
This was my biggest fear with this. I have nothing else but Zoom.
That's what I was telling you guys. If you want to try it before ex- dress rehearsal, I call it. Anyway, go ahead. Go ahead. Now I can see it. Yes.
Okay, fantastic. So the professors I'm going to go back, just show you, here are my collaborators, Professors Stevens and Dr. White, and of course, Grace Templeton, who I'm very appreciative of. The Ride Center and is multifaceted, and as you can see in the video, the different tools and how they're being utilized, and the different equipment that we have. And as I indicated, this pilot course is all about exploring reproductive and pregnancy. The faculty, the professors who are teaching this course want the students to not only think about pregnancy through various lenses that include molecular, cellular, biological, but complications and societal disparities in reproductive outcomes, and even accessibility to different aspects that lead to successful outcomes. They also want the students to think about and assess the validity of the sources and the information that they are coming across, and they want them to be able to communicate that information both through a scientific process, but also one that engages the public. And in particular, this semester, they focused on the impact of women's health and in society. The project that they came to me with is the students. So essentially, the students for the first 5 weeks of the course were exposed to a variety of topics related to sex, reproduction, contraception, embryonic development, miscarriages, and so on. And in week 6, the professors brought the students to the Ride Center, and Grace and I worked with them to try and consider the topics that they would like to focus on in order to create a public service announcement, a PSA. And the students during that time, Grace talked to them about all of the different tools, technologies, pros and cons, and we showed them examples of output. And as a whole class, they were essentially tasked with focusing on what tool they wanted to use or tools they wanted to use in order to create this PSA, and what did they want this public service announcement to look like. So what the students decided to focus on as a whole class was contraception. And so before I go into that, the tool that they decided to focus on is the laser cutter. And Grace is going to play the short video here to show you how the laser cutter works if you're not familiar with it. But essentially, it's a really versatile, powerful piece of equipment that uses photons of light in order to engrave or to cut different aspects of material, and in this case, wood. So what the students decided to do is focus on contraception. And within that classroom, I believe of 16 students, they were then paired into 8 groups, and each group was asked to focus on one aspect of contraception. And with these students being of college age, you can imagine that contraception is very near and dear to them, and a topic that they felt that their peers would be very much interested in. So before they can laser cut these beautiful panels, they had to learn how to use a different form of technology. And so they were exposed to Canva, which is easily accessible and is free to use. And that Canva helped them design their ideas, their thought processes. And each team then within the context of contraception had to talk about what is it. So they explained what the contraception is. They explained how it works. They explained the cost and the pros and cons of it. And some groups, in addition to using the laser cutter to engrave these beautiful tablets, went a step further and used other tools that we had on hand. So for example, if you look at the lower panel looking at implantables, they learned how to use mold making technologies and 3D printing to show the actual size of the implant and the rigidity of it and how it would feel under your skin. So that circle, that mold, parallels what your skin would feel like. And so if you push on it, you could feel what the implant would feel like. And if you look at the IUDs were also 3D printed by the students. And again, they wanted to demonstrate and show students the actual size of it and what it would look like in addition to how it works. The same with the pill. So the students went above and beyond what they needed to do because they engaged so wholly in this knowledge that they wanted to share with others. We then, after this was all completed, you can even see the condoms, a student even created a box and they worked with health services to get free condoms. We put this display in our storefront and then now it lives in the halls of the biology department. So a lot of students walk by it. And I was told that the condoms went very, very quickly. So I think that it's going to be their mission to try and make sure that it's refreshed and replenished for users. The other thing that they ended up doing was actually creating a panel about health services. Where do you get these services? Who can you speak with? How do you contact individuals? And one of the, I think, important things for me is to better understand the impact that the center and these tools have, not only on the students, but also on the faculty. So the impact on the faculty and the institution as a whole is that the students are exposing their knowledge and engaging with others through their knowledge and through these prototypes that they've created in ways that they didn't maybe imagine and don't necessarily have to be there in one-on-one. The users can look at this whenever they want to. So for faculty, it provides a creative approach to teaching really complex material. It provides them with meaningful applications of theories and concepts to better engage the students with and to also engage them in scholarship. And it helps them to be able to it helps the students demonstrate their critical skills in novel ways that are really more impactful for them. This storefront that I'm showing you right now is from last year. So this is the second year for this pilot course. Last year, the class decided, again, that they wanted to use a laser cutter, so they were really fascinated by it. But they wanted to focus on the myths and the facts of the first trimester. So this was very engaging for them. Here are the students from this cohort. And the impact on the students was based on both feedback that I received from the professors, but also feedback that I received from the students. And so they felt that this kind of engagement with these fabrication tools and technologies, just democratizing ways of engaging in communication, helped to drive critical topics that they wanted to present to their peers. It helped them realize how little they knew about contraception, and it helped empower them to be creative. And many of them actually said they were inspired to pursue careers that are focused on women's health, which I think was surprising to all of us. Um, we've done this with other classes. This is an example of a class that a nursing class where they're coming into the center and they are being challenged to create nebulizers out of materials you would find in a garage. And so as you're watching this video, I'll talk about some of the transferable skills, but this is I think I really wanted to share with you the enthusiasm the students have. So Grace, if you don't mind playing the video, I'd really appreciate it.
Yeah, I'm just going to unmute myself so I can turn it up.
Bicycle pump, and it was really cool. As a nurse, built aerosol masks out of a bicycle pump, and it was really cool. As a nurse, you kind of are always on your job. If you're somewhere and there's a crisis, you're kind of the most qualified person there. So it's good that we were able to use resources that you can kind of find anywhere, because a lot of people can sometimes have like asthma attacks and have trouble breathing. So it's easy to find something quick that you can just put together, and maybe you can even help someone save a life.
Yeah, and so, hopefully you can see the enthusiasm the students have, and some of the things that you didn't hear, because I wanted to keep the video really short, is a level of confidence that they're gaining in their knowledge and their abilities to help others. And so the center serves as an opportunity for transferable skills that include successful collaboration, communicating effectively, employing evidence-based approaches and knowledge. It's helping them to develop inquiry and ask more questions and to problem solve, developing personal and professional identities, which is a really important one, and persistence and resilience to setbacks. And so I think those are all impacts that the students and these classes are having within the collaboration in the center. And so I really, really want to thank my collaborators, Dr. Jess Stevens and Dr. Robin White, for entrusting me to kind of lead their students in a different way. Grace Templeton for all her tireless efforts in order to train these students and to help me run the center in an effective way. The Bio 103 students who were brave enough to tackle these, and of course, institutional advancement team, which I'm a part of, to help support funding for the tools, for the material. We don't charge students to utilize any of this because we want to remove the obstacle of cost as a reason for not engaging with tools and technologies to leverage their learning. And this is all because of the Westfield State University Foundation and my colleague Ryan Mearsman, Director of WSU Alum Relations, who I really appreciate bringing this opportunity to share what we're doing together with our students. So with that, I thank you.
Well, thank you very much. It was an excellent presentation. And Grace, come again. I think we need you to fix our computers for sure. Let me stop recording. Stop recording.